Good afternoon, everyone. COE RIMS Manipur welcomes all the participants for today's RDLS session. Today's topic is aging with HIV, and the speaker is Dr. T. Jeeten Kumar Singh, sir. Dr. T. Jeeten Kumar Singh, sir, is currently working as professor with the Department of Medicine at Regional Institute of Medical Sciences, that is RIMS, Imphal. He is the former Deputy Program Director for the Center of Excellence at RIMS. He has published more than 50 papers in national and international journals. He is a master trainer for NACO trainings conducted for various cadres. He has also spearheaded the institutional Universal Work Precautions campaign. We welcome you, sir, for today's session and request you to start the session.
Thank you very much for the kind words. Nice introduction, in fact. Good afternoon, everyone, and welcome to the RDLS series. And today's topic is on aging with HIV. I will be covering this talk with next 1 hour, under the heading of understanding the changing trends in the age of the HIV population. And then this will be followed by considerations that we have to take before treating HIV in aging population. And thereafter, we will have a look at the ways of managing AIDS-related non-HIV comorbidities, diabetes, CV disease, osteoporosis, renal disease, and hypertension. I'll be covering briefly the non-AIDS malignancies, the mental health, and the issue occurs as we discuss about the old age. We have to discuss about the issue of frailty as well. And thereafter, we will have a slide, 1 or 2 slides on the concluding remark. Now, all of us agree that there is aging of HIV population globally. It's a global phenomena. And in our context, in our national context also, there is an aging of the population in India. So according to the estimation of the HIV modeling under NSCP, what we find is that looking back at 2005, the proportion of the people, as we see the graph here, the population of the HIV population was mainly confined in the age group below 40 years. We find a huge sum of the HIV patients were in the age group 25 to 40 years, way back in the year 2005. It was in 2004 the National ART program was launched, and then since then it has been about many years now. And in fact, as we progress 2010, 2015, 2020, and as per the estimates that we have in 2025, the population, HIV population, the age of the HIV population is even more than 60% in our context is above the age of 50 years old. As per the CDC report of 2023, more than 34% of the HIV population is more than 55 years, and the majority of them are in the late critical state of the infection. So therefore, the issue of aging in HIV population is a non-fact. Now, coming to the next slide, we will try to understand and compare the overall and comorbid conditions, like free life expectancy between insured adults with HIV or without HIV infection. This is data from 2000 to 2016. Now, in this particular slide, what we are trying to understand is the expected time remaining at 21 years after 21 years. So a patient 2000 to 2003, 2004 to 7, and then 2008 to 2010, 2011 to 2013, and now in 2004 to 2016. What we find is that the infection comorbidity-free years for a patient with HIV infection, there is only marginal increase in the comorbidity-free years. And so also, if you see the yellow graph, that is yellow points, we see that almost in the HIV, without the HIV infection, the comorbidity-free years is marginally ahead of the HIV infection. So comorbidity do come, but the graph that we are able to see is that since 2008, their comorbidity-free years are a little better than that of the patients with HIV infection. Very interesting trend in this particular picture is the upward trend that we are able to see, a dramatic trend for the patients with HIV infection in terms of their overall total years life expectancy. So this is of interest because this has brought about basically because thanks to the antiretroviral therapy effectiveness, therefore patients are living longer. And when the patients are living longer, definitely the population of the patients with HIV will definitely swell up in all years. So what we are able to find today, more than 50% of the HIV population belonging to the group above 50 years is partly explained by this particular slide. What we see here in this slide is that HIV/AIDS in patients more than 50 years. This may be basically under three headings. Can we discuss why there is increased number of patients above 50 years of the HIV? One important big chunk of these patients' load is being the growing old with HIV, because earlier in the early phase of the epidemic, what we thought was that once a patient is diagnosed with HIV, the lifespan is very much reduced. As a result, people thought that 2 years, 3 years, livelihood is going to be of great difficulty. But that concept has been changed. Now we think that we know that antiretroviral therapy has brought about a change in our concept in terms of understanding that HIV/AIDS can be managed like any other chronic illness like diabetes or hypertension because of the effectiveness of the antiretroviral therapy that is available. Therefore, the patients being diagnosed in the young age, they are growing old now with the effective antiretroviral therapy. About 55% of this patient population belongs to this group of patients. Now, some of these old patients, more than 50 years, may be diagnosed late in the course. Some of them may actually be having a new infection. The lack of awareness of HIV, one of the reasons is the lack of awareness of HIV risk factors. They may not foresee, and some older people are newly single. When they are newly single, like widowers, divorcing, and while married, they have ignored, usually they may ignore HIV preventive messages. So there is lack of awareness as well. So very little HIV prevention education is targeted at them. There is low condom use. So all these factors might contribute to new infections in this whole age group. Another area that we have to take care of is, which is contributing significantly to the patient load of HIV over 50 years, is that they are being diagnosed late. Some of the important reasons are that low voluntary testing, all age, because of the stigma associated with HIV still, it is there. So they think that the low voluntary testing is one of the reasons. So they are prevented from accessing the services that is being provided. Failure of physicians to suspect HIV or screen for risky behavior because of the age, and it is also not a very comfortable exercise for a doctor to screen for a patient for HIV for a patient more than 50 years, elderly patients. So doctors may find screening for risk behavior difficult in this age group. Some of them, they present late for diagnosis and care. And on top of that, some of the manifestation of the HIV may in fact be simulating that with that of a comorbid condition like diabetes or hypertension or dyslipidemia or metabolic disease process. So it may be delayed. It may be in a way can be covered by the basic disease process, the comorbid condition rather than the HIV. So they may be diagnosed late and the care may be accessed late in the course. So these are some of the important points as to why we have a swelling of the population of the HIV more than 50 years. So what are the important things that we have to consider before treating HIV in aging? What is the significance? Let us try to understand. The significance is that there is changing pattern of the causes of death. Ultimately, when we manage the case of HIV, we are trying essentially to take care of two things. One is the morbidity part, Another is the decreasing the or checking the mortality to bring it down. Now, what we find in the early years, 1984 to 1995, it's a Swiss HIV cohort study in 3 different time periods. What we found in the early days of the HIV pandemic was that the age was one of the major cause of death in this particular study. And what we find is a non-age causes like non-age malignancy, non-age infection, lungs infection, and other causes were occupying this small segment. Therefore, to a great extent, age causes of death were the main important factors in the early part of the epidemic. As we go along, 1996 to 2004, and then we find that there is gradual shrinking of the cause of death for the AIDS patients and growing enlargement and expansion of the non-S infection and other unknown factors. And yet again, in 2005 to 2009, because of the antiretroviral therapy, what we find is that the causes of death because of the AIDS is much, much smaller now. Major sunk, huge sunk is being taken over by non-AIDS causes. So therefore, when we are dealing with all AIDS, we know that we realize that AIDS is one thing, of course, but the non-AIDS comorbid conditions is one of the important factors to be taken care of. 10 top causes of death, let us analyze. Say heart attack about 16. So let us see that communicable diseases, these communicable diseases like diarrheal disease, tuberculosis have decreased over the period of time. That is changed for 2005 to 2015. What we are able to understand is that non-communicable causes is increasing to a great extent. Whereas the red bars, red horizontal bars, that is communicable diseases, much decreased. So this is telling that the non-communicable issues are growing. And of importance is that diabetes, which was very, very small segment, covering small segment earlier in 2005, now it has grown up to 35 plus and 21 plus. Essentially, the message here from this slide is that the communicable diseases have decreased, but the non-communicable issues, diseases, comorbid conditions have increased dramatically over this period of time. Now, this is a study in the non-HIV comorbidities, number of comorbidities per patient. This study was done in Netherlands. What we find is that in the different age groups, in a different age group, the 45 to 50 years, 50 to 55, and then ultimately 65 plus, what we find is that the number of comorbidities a patient can have is 3 yellow, and then 2 comorbidities green, and then 1 comorbid condition is yellow, and then this light blue is no comorbid condition. So in the early year, in the young age 40 to 50, what we find is that patients usually have no major patients, they have maybe 1 comorbid condition or 2 comorbid condition. As the age expands, as the age grows, and then definitely what we are able to find is that the comorbid condition is swelling up, is increasing. So as we get older, we find that the comorbid conditions are increasing. In case of the HIV positive patients also, this increase in the comorbid condition is much magnified. This is of interest because when we are dealing with antiretroviral therapy for this group of patients, we cannot always be depending for the outcome, good outcome only with the antiretroviral therapy, unless we take care of these comorbid conditions. We diagnose them early and then assess and then manage them effectively. The outcome of the antiretroviral therapy also may be challenged, may be compromised. Therefore, this study says that the message that we can get from this particular slide is that comorbid conditions are there in the not HIV negative patients, but it is far magnified, much magnified in the HIV positive patients in the old age. Now, again, this is in agreement with the earlier slides, the findings of the Netherlands study, the Swiss study. This is a Swiss, again, HIV cohort study where in this prospective observational study, we find it less than 50 years, no co-medication. And then if there is increased number of comorbid condition, definitely the patient, individuals taking one co-medication, two medication is much elevated. But as the age grows more than 65 years, what we find is the segment of the no co-medication is decreased, and then more than 50% of the patients are taking either more than one medication, or two, or three, or even four. So which was not significant below 50 years of age. Now what we find is that more than 65 years old patient, HIV patient, may in fact be taking four different co-medications. So this will have to be factored when we are managing a case of HIV, especially in the old age, like the management of the young patients with HIV. So we have the issues of the comorbid conditions. We have the issues, associated issues of the patient's polypharmacy. Patient may be taking maybe four co-medications, which has direct implication in terms of choosing the right antiretroviral therapy, right molecule, and so also our follow-up plan and overall management plan, because drug interaction can be there, and choosing the right drug, right antiretroviral therapy is of immense importance. So what is the implication for the patient? Managing age-related non-HIV comorbidities is very much in the agenda, because it is not only the HIV that will have to be dealt with. We will know in the subsequent slides that even if we have taken care of the long-term livelihood, I mean the longevity of the patients, there remains some degree of immune activation in that patient. Therefore, this can also enhance the damaging property of the comorbid conditions the patient is having. Therefore, managing age-related non-HIV comorbidity is of immense importance. What does it mean? It means it will be translated to increasing expenses with decreasing income. As we all know, 50 years, 60 years, the income generation is much decreased, and therefore they will be depending on other source of income, which is not very regular, and therefore they will be out of work. And this is again a problem, because buying four different drugs and then managing the investigations, the complications, adverse effects, and so also the common condition may be a problem for these patients. There will be pill burden as well. Pill burden, 4 plus 4 different drugs, comorbid conditions, and on top of that, patient will have to take antiretroviral therapy. So pill burden is another issue. And then increasing visits to doctors and laboratory. Obviously, when we are dealing with comorbidities, as many as 2 comorbid conditions, 3 comorbid conditions, and antiretroviral therapy has its own plan of follow-up and management. Therefore, increasing visits to doctors and labs is again a problem for these patients. Restricted mobility is very much understandable, and therefore increasing dependence because of the restricted mobility. So all these are some of the fallout that is resulted because of the non-HIV comorbidity management for this group of patients. Now, does ART solve everything? That is something that we have to ask and understand. Definitely ART decreases even risks that all of us will know, but does not normalize it. Does not normalize it, because we can compare these two bars, horizontal bar. So this is for the non-S mortality after HIV diagnosis. We know that ART is doing a big job. It has, in fact, changed our understanding about HIV. It has brought about a significant change in the concept and stigma in the minds of the people. But the all-cause mortality is much decreased, 24.3 to 2.8. So it has been shrunken from the deep blue to the light blue. It has been decreased. Non-S deaths also been decreased, 0.6.1 to 1.6. Non-S infection has been drastically decreased, and so also non-S concept also has been decreased. What we find is that almost all the conditions, non-S conditions, have decreased significantly, drastically, but yet it is above 1, which means in spite of the base effectiveness of the antiretroviral therapy, in spite of the good outcome of the antiretroviral therapy, in terms of decreasing the ratio of the individuals diagnosed with this comorbid conditions, these event risks, there is always a running background immunologic response that carries on and that can have impediments in the management of the comorbid conditions. That can aggravate the comorbid conditions and that can in a way adversely impact on the outcome of these patients' management. We do know that there are risks with aging in HIV, how it comes. There is a triad of things. And this diabetes, cardiovascular disease, non-S malignancies, renal disease and hypertension, osteoporosis, they are the issues in the old age. So the aging population in the HIV, one of the major problems is because of development of this, because of the old age, they are destined to develop some of these patients. So on top of that, these patients of HIV, because of the background immune activation, because of the HIV, even if ART has taken care of the long-term survival, there remains still some inflammatory condition, inflammatory reaction, and that can either enhance or impede, cause impediment in terms of full effective on the therapy of these conditions. So these three triads are very, very important. The patient's individual genetics, the menopause conditions, the hair of traditional risk factors. Smoking is one of the important things. Dyslipidemia, hypertension, diabetes, these are what we call as a traditional risk factor, like obesity, diet and physical inactivity, and poverty again. So patient factors are there that can have a contribution to the development of these risks. Virus itself, HIV virus itself, even if ART is being given, effectiveness is achieved in terms of virological suppression, but there will be some background inflammation baseline going on that can cause problem. Inflammation and immune activation, and more importantly, the co-infection associated with HIV like hepatitis C virus also is known to cause some background immune activation and inflammation, and that will have an adverse effect on the overall manifestation and treatment outcome of these conditions. The treatment that we are using in terms of the ART, we will have to consider toxicity of some of these drugs. Some of the ART drugs component of the ART do have impact on the diabetes. We will get to learn in the subsequent slides. There was some adverse effect on the cardiovascular disease through their effect on the lipid metabolism and non-AIDS malignancy, so also in the renal diseases and osteoporosis. So in a way, it is a triad of things that we'll have to understand in understanding the overall status of these comorbid conditions in the elderly population. HIV. Now let us understand the non-HIV comorbid, that is diabetes mellitus. Now there is relative risks of diabetes in an HIV infected to the tune of about 1.2 to 2%. There is prevalence of impaired glucose tolerance, about some studies says about 25 to 35%, so 18 to 35%, and 9% of them may actually have diabetes. Interesting thing that we need to keep in mind is that glycosylated hemoglobin underestimates glycemia in HIV infected persons. That we see here for a sugar level of 150, non-HIV control. Control will give about 7.5, and there is underestimation of the glycemia in HIV infected person. So glycosylated hemoglobin may not give us the true picture of glycemia. Then what do we do in terms of the diagnosis? So that will come in the subsequent slide. Now, let us try to understand the metabolic syndrome, because it has an impact on the development, the likelihood of diabetes or the impaired glucose tolerance. So it depends upon the definition that we use for the metabolic syndrome. This is the slide. There are different definitions of, about metabolic syndrome, but one that we use is waist circumference 90 centimeter in the male, 80 centimeter in the woman is considered for this particular proposal as visceral obesity. And then in case of the low HDL cholesterol, less than 40 in male, less than 50 in female, high triglyceride means triglyceride more than 150 or being treated for it. And then insulin resistance, fasting glucose more than 100 or being treated for hyperglycemia, then diabetes, fasting blood sugar more than 126, postprandial blood sugar more than 200. So this is the contribution from the insulin resistance. And of course, the hypertension, which is defined as systolic BP more than 140 and or diastolic more than 90 millimeter of mercury or being treated for hypertension. If we have at least 3 out of these different factors, then we refer to as metabolic syndrome. Diabetes screening and management. How do we screen and diagnose and manage these cases? Now, fasting blood sugar should be done. If it is more than 126, should be a case of diabetes. If we have somewhere between 100 to 125, that is lesser than 126, we should consider going for a post-meal, that is saline test. We give 75 gram oral glucose tolerance test. Then only we'll be able to diagnose a case of diabetes if the sugar level is between, fasting level is between 100 to 125. Now, as I said earlier, the glycosylated hemoglobin threshold cannot be as that of a normal usual general population, because for HIV uninfected patients, more than 6.5 is considered to be diabetes. So fasting blood glucose every 6 to 12 months in all patients should be done, and consider testing 1 to 3 months after starting or modifying antiretroviral therapy. Some of the common drugs, ART drugs, antiretroviral therapy drugs that we understand to be contributing in development of the hyperglycemia is the lopinavir, and then of course the new drug that we are using as a backbone molecule in the national ART program, that is dolutegravir. And some NRTs have also been proposed, but then definite evidence for this is yet to be found. Now, how to manage is it should be individualized. There cannot be a fixed formula for everyone developing this diabetes. It has to be an individualized approach depending upon their liver status, their kidney status, their log profile, and then the concomitant antiretroviral therapy, the molecule the patient is taking. So goal for prevention of complication would be glycosylated hemoglobin less than 7 to 8%. When we decide to treat these patients, we need to keep in mind the different drugs, oral hypoglycemic drugs, and some DTP4 inhibitors, SGLT2 inhibitors, new drugs, and others like carbos. So what we find is that the majority of the protease inhibitors, they have got issues. Majority of the protease inhibitors have got issues in terms of the interaction with the different oral hypoglycemic agents. And so also the NNRTI also do have some adverse effect with the oral hypoglycemic drugs. But what we find here interestingly is that the TDF, the national ART backbone molecule, that is TDF, we don't find much interaction except for the SGLT2 inhibitor like ziflozin, and so also the empagliflozin, but there is no adverse thing with the dapagliflozin as far as the TDF is concerned. And for the lamivudine, there is no drug interaction significant being reported with any of these oral hypoglycemic drug. And interestingly, for the dolutegravir, again, a very effective drug and one of the important components of today's antiretroviral therapy in different regimes. But one word of caution for dolutegravir is that when we are giving with metformin, we have to be cautious because it can increase the bioavailability of the metformin by a great extent, and then patient may, if we do not do proper follow-up, may develop hypoglycemia. So that is one fear, of course, but by and large, dolutegravir is very much compatible with almost all the oral hypoglycemic drugs. Let us go to the cardiovascular disease. We know that there is changing cardiovascular risk burden because of the age, about 50 years, because of the age, and also because of the HIV infection. There is increased longevity, which is brought about by the antiretroviral therapy. So therefore, increased prevalence of CVD is only logical. Now, PLHIV has got twofold increased risks of coronary artery disease, and the 4.5-fold increased risk of sudden cardiac death. Sudden cardiac death in case of among the HIV population is something that we should keep in mind. And this is further increased in this old age. Therefore, 4.5-fold increased risk and 2-fold increased risk of coronary artery disease. So we should be focusing our mind in managing on severe risk burden when we are dealing with HIV in all ages. What we find is a USAC is an interesting graph here. The relationship between cardiovascular disease risk in HIV and HIV treatment is USAC. In the beginning, pre-treatment, what we find is there is a high CVD risk. Now, there is rapid decrease after starting antiretroviral therapy. Rapid decrease after 1 year or so. Rapid decrease after starting. Thereafter, in spite of the fact that ART is good, it has changed the definition of the HIV in terms of the minds and the perception and the stigma in the minds of the Ghanaian population, HIV population. What we find here is that in spite of the base effectiveness, base effort that we are making with use of the antiretroviral therapy, what we find is the cardiovascular disease risk is increasing. This is a very interesting finding. This may be due to the moderate increase over time, may be driven by the traditional risk factors of like smoking, diabetes, obesity, all those components that we have discussed under the heading of the metabolic syndrome may be at play. At the same time, even if the HIV viral replication being taken care of by the antiretroviral therapy, there is a persistent inflammation going on. There is persistent inflammation going on amongst the HIV patients. Therefore, this may be one of the factors. And of course, some of the drugs that we are taking, for example, abacavir in some of these studies is reported to be causing some cardiovascular adverse effects. So this we should keep in mind. How do we manage cardiovascular risks? We must first identify those at risk cardiovascular disease risk factor. Is the patient hypertensive? Is he diabetic? Dyslipidemia status, obesity, BMI more than 30 kg per meter square, and then one of the components of the metabolic syndrome. In fact, some of the important components of the metabolic syndrome, physical inactivity is important. So also tobacco use in different form, tobacco use, alcohol consumption, excessive alcohol consumption is also a risk factor of these patients. Unhealthy diet and nutrition and strong family history of cardiovascular events of the disease is something that we must keep in mind in terms of identifying those at risk. Risk assessment should follow the next step. We must ask for the heart attack. It will be done at the time of registration in the HIV care or ART initiation. Then that is not the end. We must repeat this again at 3 months because some of the risk factors may change, may develop in due course. So we need to follow up baseline, 3 months, and 6 months of ART, and shall be repeated every 6 months thereafter. Because let us not forget, we are dealing with elderly population, more so with a chronic inflammatory condition. Therefore, we have to be cautious. We ask for history of heart disease, stroke, diabetes, and hypertension, any angina, breathlessness on exertion and lying flat, numbness or weakness of the limbs, loss of weight, for example. Any past or present treatment or the medications should be ascertained, and then tobacco use again and alcohol consumption should also be documented and asked for very, very carefully, because these things can change the ultimate outcome, the destiny of the patient's outcome in the long term. The lifestyle, whether the patient is leading a sedentary lifestyle or an active lifestyle, this also should be assessed. Premature heart disease or stroke in the past relative should also be recorded. Now we will assess what is the BMI of the patient. We know that obesity is a problem in terms of the cardiovascular outcome. Waist circumference is a problem, is a component of the metabolic syndrome. We know that hypertension is a very, very important factor in terms of bringing about adverse outcome, and one of the important components of the metabolic syndrome. Signs and symptoms of diabetes, because diabetes is, India is going to be the capital of diabetes very soon, and that is being projected. And on top of that, if the patient is having HIV because of the chronic inflammation, that is, even if the longevity is increased because of the good effect of the ART, we will have to deal with this. So we must ascertain and assess the diabetic status. Examine for signs such as pitting edema, maybe due to drug effect, maybe due to kidney disease, maybe due to heart disease, maybe due to liver disease. So these things should be examined, and then heart murmurs should be examined. So also vessel crepitation in lung and tenderness of the abdomen. Lipid profile is important. If available, lipid profile is available. If available, should also be ascertained. Now, what is the plan for the management? Step 3 in managing cardiometabolic factors. The most important one is the lifestyle modification. Easy to say, but sometimes it is not easy to be administered, not easy to be followed in a long-term basis. But we must always endeavor to keep stress on lifestyle modification for all lifestyle modification has very impact on the management and outcome of these patients. In terms of the pharmacological therapy, we have to choose a lipid step antiretroviral. We do know that ART is doing its work in terms of viral application, but then it may have adverse effect on the lipid. Therefore, some of the ART, like protease inhibitor, may be doing good for the virus, but it may be having damaging effect on the lipid homeostasis. Therefore, we should choose in this group of patients lipid step ART. Lipid lowering therapy will have to be decided. We will have to choose lipid lowering therapy. Management of metabolic syndrome goes without saying, and diabetes, of course. Metformin has special place in terms of management of diabetic or ICT patients. If there is evidence of insulin resistance, the patient's abdomen waist circumference is big, there is BMI is very high, and then fatty collection is there, and then insulin resistance is there, then metabolic metformin also does very well along with lifestyle modification. We must consider avoiding abacavir in patients at elevated risk of cardiovascular disease. Some of these studies says that abacavir is reported to have some risk for cardiovascular disease outcome. So management, again, to repeat, there are three things. One is the A, one is the B, one is the simple things, A, B, C. If we follow this, probably will make a difference in terms of the outcome. This holds true not only for the HIV patients, for all the group of patients, for the general population as well. But more important thing is, as we are dealing with HIV patients, this is the mantra for longevity, for overall good outcome. That is lifestyle modifications for all of. We must avoid tobacco. What is A? Avoid tobacco. Do not smoke. Smoking cigarettes greatly increases your risk for heart disease. So this is number one. Next thing would be B. What is be more active? How can we be active? We can be active by exercising. Get at least 150 minutes of exercise a week to lower cholesterol and blood pressure. So also it has got impact on aging process itself. So exercise, so be more active. What is a C? Choose better nutrition. Nutrition is very, very important in terms of managing the comorbid conditions that we have described. Eat healthy, eat foods high in fiber and low in saturated fat. Anything that solidifies in cold weather, that is like ghee and all this, they are saturated fat and sugar. Trans fat also should be avoided. Salt also should be avoided, and cholesterol should be avoided. We increase high fiber food. So if we are taking care of A, B, C of lifestyle modification, I think we will be able to engage with this head on. Now, this is the development of metabolic syndrome by intervention group in diabetes prevention program. And here what we have studied is the cumulative incidence of the metabolic syndrome. You choose some patients of impaired glucose tolerance. Then we see the development of the diabetes. So what we find is that the lifestyle modification, metformin, the chance of development below 45% of these patients, chance of development of the metabolic syndrome is taken care of by lifestyle. Base is the lifestyle. Only 30 of them will develop. Metformin, around 45%, and placebo to the tune of about 60% cumulative incidence on metabolic syndrome development. So what we are able to understand here in this, the lifestyle, those who are avoiding tobacco, those who are being active, those who choose better nutrition, that is the best, giving the best result in terms of preventing development of the metabolic syndrome. Of course, when we prevent the metabolic syndrome development, then obviously the ill effects of some comorbid condition like diabetes, hypertension, this lipidemia will be taken care of. So lifestyle is the base. Next comes the metformin, and of course, placebo, much better than the placebo. So when we combine these two things, lifestyle and metformin, it will do wonder in terms of the outcome of these patients. When we manage these patients, let us always keep in mind that we are using antiretroviral therapy. Yet we have to tackle the lipids. How do we do? We must understand that the traditional, what we have been using, the PIs, atazanavir, ritonavir, and darunavir, and all these drugs, they have got very high adverse effect on the lipid homeostasis. Efavirenz is a little lesser. Abacavir a little lesser. Ribavirin a little lesser. And of course, TAP with tenofovir alafenamide, raltegravir, DTZ, BIC, they are still better and best, of course, in terms of the TDF for the lipid considerations. I think this is the best drug. So these drugs, they cause very little effect on the antiretroviral therapy. Managing hyperlipidemia, we use the National Lipid Association criteria, count the risk factors, add HIV as an additional factor. Now we divide these patients into these 4 different groups: low risk, moderate risk, high risk, very high risk. If the patient has got low risk, like 101 measure atherosclerotic cardiovascular risk factor, that we will come to know in the subsequent slide. Consider other risk indicators. Now the issue here is consider drug therapy if the LDL is more than 190 and non-HDL and LDL more than 160. Now in these patient groups, how far you have to bring it down? We can bring it down to 130, non-HDL less than 130 and LDL less than 100. Now for the moderate risk patients, to measure atherosclerotic cardiovascular disease risk factor, consider risk scoring and consider the risk indicators. So in all these low risk, moderate risk, and high risk, what we understand is that different levels, thresholds of initiating lipid is there, but the commonality of this recommendation is that any patient with any degree of risk, if it is late, the target should be less than 130 non-HDL and LDL less than 100, except in patients with very high risk here, diabetes, for example, with more than 2 risk factors or organ damage, right? Then the target is different in these group of patients. For the low, moderate, and high risk, it was less than 130 non-HDL and LDL less than 100. But in case of the patient with very high risk, we have to target less than 100 non-HDL, and even further going down, the LDL will have to be brought down below 70. So this is all about the recommendations. Now about the anti-lipid therapy, the basic, we are fortunate, the basic national antiretroviral drugs that are tenofovir, zitobodine, NRTI, so to say, lamivudine, they don't have any significant interaction with the anti-lipid therapy. So also the dolutegravir, we don't have much interaction with this drug. But in terms of the interaction between the antiretroviral therapy, PI group of drugs, and so also some of the NRTIs, there is significant interaction, especially the simvastatin and lovastatin. But rosuvastatin can be used to some extent, so also the atorvastatin, but we should be careful with simvastatin and lovastatin. So the message from here is that we should be careful using anti-lipid along with the PI group of drugs and NRTIs, but the basic reason that is being provided in the NSM program do not have much of a significant interaction. Now, another thing would be, in case of the patients coming with high triglycerides, zampironidazole be avoided with atazanavir, and so also with darunavir, so also with lopinavir. But we can choose fenofibrate. So the best option that usually we can depend on managing anti-lipid in this group patient is the atorvastatin, of course, rosuvastatin, lipid statin, so to say, and the fenofibrate combination can be made use to manage lipid. Lipid-lowering therapy, statins used to cause 44% reduction in CVD events. Fibrates, fenofibrate, consider when TZ is more than 400, and other drugs also can be used. Usual dose is 40 to 80 for the atorvastatin, 10 to 20 for the rosuvastatin. As I said earlier, simvastatin and lovastatin are considered contraindicated with protease inhibitors because of the interaction. We can use one risk estimator, which is available online, American College of Cardiology. So we put all these parameters and then we define the different risk factor, the lifetime atherosclerotic cardiovascular risk factor, depending upon which we can also assess the requirement of the anti-lipid therapy and other measures that has to be taken care of. So project risk reduction by therapy of this particular patient. So BP, what we have to do for BP, for the LDL, dictionary authority statin recommended after clinician patient discussion. So diabetes will have to be managed. Smoking will have to be advised to stop. The patient should be advised. And so also low dose aspirin might be considered to so depending upon the risk outcome and these different components of the management will have to be undertaken. Lifestyle, the most important way to prevent atherosclerotic cardiovascular disease is to promote a healthy lifestyle throughout life. Medications to reduce risks should only be considered part of the shared decision-making process for optimum treatment when patient's risk is very high. So therefore, this can be accessed online and we can calculate the risk there. These patients, HIV, and especially in the old age, definitely they have got bone mineral density, osteopenia, osteoporosis, and of course, the fall and the resultant fracture and avascular necrosis. Again, triad of things will define this. The patient's hypogonadism, patient's conditions like gender menopause, vitamin D deficiency, poor nutrition, poor calcium intake, hypothyroidism. These are some of the important traditional risk factors as well, some of the important patient characteristics. And the virus itself, even if we have defined the longevity of the patients with ART, there remains some inflammation, and that can stimulate the osteoclast, and that can cause the decrease in the bone mineral density. ART and toxicity also do have, so also the glucocorticoids have adverse effects. Some of the drugs, we are not using it, monitoring it, and accordingly modifying the treatment, we can also have adverse effect on the overall bone mineral density. What we have in this slide is 6.4 increased risk of low bone mineral density and 3.7-fold increased risk of osteoporosis. What for women? It is going up. This is for the non-HIV patients. As we get any lady 50 years, when she's as at about 70 years, the chance of osteoporosis definitely there. But then it is increased much more in the HIV population. This will have to take care. And among the male, it usually maintains a little bit goes down, but then in the HIV population, it goes up. Prevalence in India is ART-9 patients, 67%. They do have this problem, osteopenia, 70%, osteoporosis, 29%. But ART experienced patients, they have more numbers, 80%. Osteopenia is 63%, osteoporosis, 36%. Now, more than 40 years, we usually score what we call as the FRAX score. If the patient has got propensity for low risk, less than 10, we assess after 2 to 3 years. There are issues regarding the admissibility, regarding the sensitivity of the FRAX score. But if we use this, we can keep this thing in mind. That is moderate risk about 10 to 20%, high risk if it is more than 20%, or fractional risk more than 3%. So in a situation like this, we can use the bisphosphonates without even going for the DXA, though preferable. But if the patient is somewhere in between 10 to 20% of the FRAX score, then DEXA be suggested. And then if the score is more than minus 2.5, we have this management protocol. And if lowest T score is less than minus 2.5, we must consider bisphosphonates. FRAX score can be calculated. And as I said earlier, the admissibility, the sensitivity of these tests is still being questioned. But this is one of the parameters. Online available, it is available, and we can measure the risks using this platform. What is the management? Management is again the lifestyle modification is very, very important. Those who are exercising regularly, physical activity, their bone health is much better. Smoking cessation is very, very important. So also the alcohol reduction. Pharmacologically, vitamin D and calcium should be supplemented in sufficient quantity, and antiretroviral therapy, TDF to abacavir, change in the TDF to abacavir is one of the options that we have, or tenofovir alapanamide. And if the patient was on PI, we have an option to go for the DTC. Bisphosphonates like alendronate and xalendronate do have good effect in management of these patients. In this study, tenofovir alapanamide regime had less impact on BMD as compared to TDF in the treatment by adults at 144. So what we find is that this is tenofovir alapanamide group, and this is the tenofovir digoxil group. So what we find is that change in from the baseline lumbar spine thing is very much maintained in case of the clinical significance is maintained in case of the patients taking tenofovir alapanamide. In terms of management, this shows that greater improvement in the BMD with zoledronic acid. So you may have a clinician, one who is dealing with this type of patient may think that switching from TDF, is it going to be okay, or do I need to go for a treatment using zoledronic? One of the studies says that the improvement change after in the lumbar spine, the change in the BMD in the lumbar spine is much better with zoledronic than changing the TDF. Therefore, zoledronic can be resorted to in managing these patients. Dolutegravir with calcium and iron. How we give dolutegravir? Dolutegravir, we know that is a principal molecule in the, it's a spine molecule in the management of HIV today in different regimes. DTG can be co-administered with calcium and iron supplement if taken with meal. Under fasted condition, the patient is not taking any food. DTG should be given 2 hours prior or 6 hours after the supplementation. It means the absorption of DTG can be impeded by taking with these molecules. That we must keep in mind. And it is increased with fatty food. We take this drug with fatty food, and then the absorption is much better. Renal disease. Individual predictors of the new onset kidney disease. Renal issue is a big problem in managing these type of patients, because many of these antiretroviral therapy, we need to change the drug depending upon the GFR, which may be calculated by one of the method, what we call as a Coco-Cowl equation. Then we have to adjust the dose of the antiretroviral therapy. So it's a community-based study, longitudinal cohort study, and odds ratio risks of developing CKD. If the BMI is high, smoking, this much, hypertension, age, diabetes, and of course, the HIV-associated nephropathy and drug use. So these patients, HIV patients, especially in this age group who are prone to develop comorbid conditions, they have a propensity to develop. They have all the elements to develop these possible nephropathy, kidney injury in different forms. So this should be kept in mind. Now, screening for the CKD, we always need to screen this patient because some of the ART, they do have adverse effect on the kidney. And at the same time, some of the drugs need to be changed. The dose needs to be modified. So how do we follow them up? By using serum creatinine, by assessing the protein in the urine. Those patients who are having GFR more than 90, protein clearance less than 200, S less than 50, we can continue. It's a low risk, we can continue the standard ART. High risk patients, GFR is decreased less than 70, protein creatinine ratio is 500, is more than 60, and patient has got associated comorbid conditions, diabetes, hypertension, uncontrolled hypertension, CBD, then we must take action, avoid nephrotoxic ART like TDF, ATVR, lopinavir. TIs generally require dose adjustment, like zidovudin, lamivudin, these things do require, except for the abacavir. So these should be assessed. We do know that there are malignancies like Kaposi sarcoma, non-Hodgkin's lymphoma, and even cervical carcinoma. So these are non-S malignancies. Cervical cancer screening visual inspection with acetic acid at the time of ART initiation should be done. Those who are positive with this should undergo pap smear. So how do we repeat this? Some of these patients may give false negative reports. That also we must keep in our mind. But repeat screening within 3 years is sufficient, study says that. if the initial test is negative, right? So women who have been treated should receive frequent follow-up, of course, at 1 year. So cervical cancer and the cause is, of course, usually the human papilloma virus. These days, we do have vaccines available for the young age population. The old age, as we are dealing with the whole HIV population, we must screen this by visual inspection with acetic acid. If positive, go for pap smear, and then if negative, repeat the screening within 3 years for appropriate action. Breast cancer as such is not considered to be, it's not being reported to be directly caused by HIV. But then given the fact that we are dealing with aged population, all women living above 50 years, naturally in general population, they should be screened for breast cancer. So all women living with HIV more than 30 years, at the time of ERT initiation, so they should be established. And then every 1 to 3 years thereafter. Screening for oral cancer is important. All PL-HIV of age more than 30 years should be screened using oral visual examination and the regular visits for those patients who are regular tobacco users, at least annually for others. Now we come to the mental health. These patients, because of the stigma, rejection by family, the fear of disease and the death, and the financial insecurity and dependence, over 75%, over 50 to 75% of the study groups of all the adults with HIV saw some kind of depression. They have got mood swing, cognitive thing is depressed, therefore causes non-adherence to all medications, including antiretroviral therapy, and therefore show the seek for non-adherence and then failure of the antiretroviral therapy. Therefore, mental health is something that we have to take care of in this group of patients. Screening for depression before initiating ART and thereafter every 6 months is recommended. We ask 2 questions importantly. During the past 2 weeks, have you often been bothered by feeling down, depressed, or hopeless? Number 2, during the past 2 weeks, have you often been bothered by little interest or pleasure in doing things? So that is how we assess depression. And because if we diagnose this early, then we can take actions. One of the antiretroviral drug that is known to cause CNS effect is rifampicin. We complain of nightmares, we complain of insomnia. So some of these drugs, like the rifampicin, will have to be switched to some other appropriate regimen. Counseling is an important part of the management. Lending a sympathetic ear, teaching coping mechanism is very important. Biofeedback mechanism is very important. Stress management is very, very essential. And then keep them busy. Keep them busy. And social network is again very, very important. Studies have shown that those patients who are engaged in social networks, they do better in terms of their ultimate mental health and the cognitive status. Medication also will have to be considered for these group of patients. Frailty is a very important thing. Frailty is almost very near to, in terms of understanding, near to aging process. About 50 years in the aging process, there is cell at the level of the cellular and the tissue level and the organ level, there is loss of homogeneity, the basic homeostatic and the hemodynamic activity of the cell and tissue level is decreased. It's a global phenomenon as we get older. But then in case of the frailty, it essentially means the pathophysiological construct is almost the same, near about, because usually the aged patients, they get frailty, usually. And the basic understanding is that in case of the frailty, it pertains more towards the motor activity, the energy level, and the neuromuscular activity. So what we find here is 3 out of 5 unintentional weight loss. If we have 3 out of the 5 following domains, like unintentional weight loss, self-reported fatigue, low physical activity levels, weakness as measured by hand grip strength, and slow walking speed. If we have 3 out of these 5, we can consider that the patient is in a state of frailty. So prevalence of frailty criteria, unintentional weight loss, the percentage of the HIV infected population is much higher than of the non-HIV. Aging is a process that is common for both non-HIV and HIV patients. But what is the difference here? We find that the non-HIV patients, they have more unintentional weight loss. HIV patients, they have more weakness than that of the non-HIV patients. Exhaustion, the HIV patients is more than that of the non-HIV. Again, it's slowness, low physical activity. So the concept of frailty is much more, is different, a little deviated from the concept of aging process. So it requires attention and investment. So we know the frailty in terms of the physical activity, the social connect, emotional liability, metabolic effect, the cognitive effect, and so on the sensory effect. Use it or lose it. Regular exercise is very, very important. The balance and flexibility training is very, very important. And of course, the nutritional interventions. And self-help groups and social network, it enhances the ultimate outcome of these patients in terms of their frailty state. So what we have to do beyond drugs, what are the issues beyond drugs, is easy prescriptions. We require easy prescriptions for these patients. Nutrition has got impact on the overall outcome and so on. So given the age, poor nutrition has adverse effect on the outcome of the associated comorbid conditions as well. Involving family is very, very important, family members, because they are dependent, these group of patients are dependent. Caregiver or support groups are very much essential for this group of patients. Open-ended questions, we cannot be engaging with this group of patients with close-ended questions. It should be open. Open-ended questions should be used when we're engaging with these group of patients. Mental health is something that we need to focus on because of the isolation and social disconnect, because of the stigma, because of the dependency, because of the high chance of development of the mood and the depression and anxiety and cognitive challenges. Avoiding multiple health visits is something that we must take care of. Patient will have to be told attending hospital for diabetes management. And again, after few days, the patient will have to be called for hypertension, for kidney disease again. So again, with the antiretroviral therapy. The word here is the comprehensive healthcare. If we are following a comprehensive healthcare for this group of patients, essentially managing HIV in the aging requires comprehensive approach. Now, this perhaps is the last slide. We must have aged with these group of patients. We must look beyond what we see, widen our management focus. We cannot be focusing mechanically on only certain aspects of the problem. We must strengthen our screening strategies, which was defined in the early part of the epidemic to manage. Now we are in a phase where we have to deal more number of patients in the elderly population, which has got a defined pathophysiology, defined comorbid, and defined a definite poor physiological condition, what we call as the geriatric issue syndromes. One-stop shop as far as possible, which will be interpreted as comprehensive management. One stop or one window kind of a service should be available, while lifestyle changes remains the most important pillar. Again, I re-emphasize lifestyle changes are very, very important. It's the most important pillar. We must consider statins because there are certain things that statins can do. Statins do have effect not only in the lipid management. Let us again revisit the literature on statin. The good effect of statin is far beyond control of the lipids. It has got impact on the even preventing the malignancies, some of the malignancies. It has got what you call as the proteolyte. It has got other effects, other good effects. Therefore, must consider statin in the right patients. How to consider, when to consider is depending upon all the scales. Bisphosphonates, when needed, should also be used as we manage the case of the osteoporosis and osteopenia. Reminding again, optimize heart. We must optimize. Vaccinate. Adult vaccination is very, very important. And vaccination during the young period of time in the early years also will have a legacy effect in the long-term outcome of some of these preventing the infectious conditions. Important thing is we need to listen to them. We need to lend our ear, give some more time and space for them. Let us not forget these patients. They require a comprehensive management, listening, quite listening to them and help them is with grace. There are some of the online tools that we can put on our table. drug interactions will have to be studied for good outcome because we are dealing with so many drugs, especially in old age. We may have to deal even for 5 different drugs with different interaction status. EGFR measurement is required because drugs will have to be dosed. You'll have to define them early, at what stage of the that means the patient is in. Bone density, as we have gone through the FRAC score, bone density is available. Cardiovascular risk scoring, the recommendation of the American Cardiology thing is college is very much available online, and drug resistance also can be accessed through these online tool. So with this thing, I have covered the spec. I think there may be some areas that we always improve upon, can discuss, but today I think this is the end of the presentation. Thank you very much.
Thank you so much, sir, for facilitating this session. Any questions from the participants, please feel free to unmute your mic. You can also put your questions in the chat box. Any questions from the participants?
Question type one.
So I don't think there are any questions. In case we have any questions later, I'll forward them to you.
Welcome, ma'am. Welcome.
Thank you so much, sir. Thank you to all the participants for patient listening. We'll conclude the session now.
Thank you. Thank you.
Thank you, sir.